just checking. Okay. Okay, I think I'm now audible. Just yes. Thank you. Okay. A very good morning once again. A very good morning, everyone. So today what we'll do, we'll take 100 questions, 100 Sawaal Bemisal, which will help everyone for preparing for FMGE exam, upcoming FMGE exam. And it will be concept based, and you have to understand the concept, because the questions which I'll be taking, that will not only help to solve the question which I'll display here, it will also help to solve the questions related to that topic. So let's start without any delay, and let's go with the first question, MCQ1, right? So let's read. And in community medicine, it's very important to understand the question, because if you understand the question properly, the half of the question is solved. Now let's read the first question. The first question says, a study was conducted to compare MMR, measles, mumps, rubella vaccine history in children with autism, right, and children without autism. So a comparison study is done. What kind of study is being done here, right? So the question says that there are children who are suffering from autism, and there are children who are not suffering from autism. So or children who are suffering from autism is already case. Can I consider it as case? Those who are not suffering from autism, can I consider it as control? So there is a study going on between case and control. So the options, if I see, by understanding the question, it cannot be cross-sectional, it cannot be cohort, it cannot be clinical trial. It is a classic example of case control study, because already children are suffering from disease. We have taken control with those children who are not suffering from autism. So this is a classic example of case control study. So the answer goes to case control study, right? Let's take the second question. Now, a study to determine the association between maternal smoking histories from pregnant women during their antenatal visits. So, a pregnant woman's, we have taken history, the study has taken history of maternal smoking and during their antenatal visits, and they're trying to subsequently assess the birth weight of the babies soon after delivery. So we are taking the history of maternal smoking during their ANC visits, and we are trying to assess the birth weight accordingly of the babies after delivery. So what type of study is this? Now, in this question, we understand one thing, that it is forward-looking study. We are moving forward in the study. So, and there is no case, there is no control. So case control cannot be the answer. It's not a cross-sectional study, it's not a snapshot study, so this cannot be also the answer. We may get confused with cohort study. Is it prospective or is it retrospective? Now, since we are moving forward, we are trying to assess the birth weight of the baby, which will happen in due course. So it cannot be a retrospective cohort. It will be definitely a prospective cohort, right? So the answer here goes with prospective cohort. Okay. Now, the questions related to this this table helps you to understand the overall concept in simple terms. Now, let's take cohort study. Cohort study can be prospective, can be retrospective, can be mixed cohort. Before I explain cohort study, please remember, cohort study in principle always is a forward-looking study, right? Whether it is a retrospective cohort or it's a prospective cohort. How we'll understand that? Let's take prospective cohort. We start the study with the exposure and we move forward, right? Suppose we have started study today and we are going to assess after 5 years. So we are moving forward to see the outcome. The study starts with exposure. It's a forward-looking study. So it's a prospective cohort study, the question which was related to that. Let's take retrospective cohort. Before explaining this, I am again saying cohort study is in principle a forward-looking study. But the word here we use is retrospective cohort. Now, how to understand this? Suppose we are in 2024. I want to check that any means, for example, MBBS students who were enrolled in for example 2019. I want to see the history of smoking. So what I will do I am in 2024. I'll go back in the time in 2019. With the help of records, I'll reach here in 2019, and then from here I'll start moving in 2020, 2021, 2023 and 2024. So in principle we are moving forward. Exposure and outcome has already occurred, but we will start the study with exposure. Means the study is in reality starting in 2024, but we are going back in the time in 2019, and from there with the help of records we are moving forward in 2024. So this is also in principle forward-looking study. If you combine these two both, it becomes a mixed cohort study, right? And then case control study, the first question, you have cases, you have control, exposure and outcome has already occurred, and since people have already developed disease, so you need to ask them. So they will recall, they will tell what has happened. So here you are going backward. You are going backward. In cross-sectional study, you don't go forward, you don't go backward. What is the status as of now? You're neither going backward, neither going forward. So the exposure and outcome is assessed at one point of time. So this is the basic difference between different types of cohort study. Why this table becomes important? Because questions are related to this. Okay. Now, here I also want to emphasize three types because MCQs are related to this. Descriptive study. Let's take descriptive study, analytical study, and experimental study. Please remember, descriptive studies are for hypothesis formulation, right? We formulate hypothesis. Now, hypothesis can be correct, can be not correct also. Now, to test this hypothesis, we do analytical study, right? So, hypothesis formulation is done by descriptive study. Hypothesis testing is done by analytical study, and there are different types of analytical study, which is ecological study, where the unit of study is population, and the rest three, cross-sectional, case control or cohort, the unit of study happens to be individual. Now, if you want to confirm that hypothesis, so then we have to do experimental study. So please remember, hypothesis formulation is done by descriptive study. Hypothesis testing is done by analytical study, and confirmation is done by experimental study. Okay. One more way of understanding is decision tree. This slide will also help you to understand what is decision tree. You have to take a decision. If I ask you one question, are you going to do any intervention in a study? Your answer can be yes. Your answer can be no. Let's take one part. If you're saying no, I don't want to do any intervention, I only want to observe, okay? Then the next question to you is, so if you're not doing any intervention, it becomes observational study. The next question is, are you going to do any comparison? You want to compare between two groups or not? Your answer can be no. Your answer can be yes. If you are not going to compare, then what are you going to do? You are only going to describe. So it becomes descriptive study, it becomes descriptive epidemiology. If you want to compare, then you are doing analysis. It becomes analytical study. Then the next question happens to be, what is the direction of the study? You say, no, there is no direction. I don't want to do, I want to assess now and give the status. So exposure and outcome is on the spot. So it is cross-sectional study, neither forward nor neither backward. In cohort study, just now I said, you start with the exposure, you move forward to check the outcome. So your forward move looking study. And in case control study, the direction is backward. You are going from the outcome to exposure. So retrospective in nature, so it becomes case control study. So this is one way of understanding. The other part, initially I asked, are you going to do any intervention? You said, if you said no, so we understood this. When you say no, I want to do experiment. So you're doing an intervention, you're giving certain drugs. No? So experimental study. The next question is, are you going to randomize or not? So you want to be fair, you don't want to be biased. So are you going to do any randomization? The answer can be yes. The answer can be no also. You say, no, I don't want to do any randomization. So then it becomes non-randomized controlled trial. And if you're doing randomization, it becomes randomized controlled trial. So this is also a way of understanding different epidemiological studies, and this way of understanding is called decision tree. Okay. Now, the third question, let's take the third question. All are true for standardized mortality ratio except. Now, whenever this except question comes, no, you need to be very careful. So the question is saying all are true for standardized mortality ratio, SMR. Now, the options are given here. So the first thing, SMR is calculated in indirect standardization. Please remember this, indirect standardization, right? Now let's see the options. Is a form of direct standardization? I'll give a thought. Is a form of indirect standardization? As I said, correct. Is calculated as observed death / expected death into 100? Correct. I'll explain this, don't worry. And permit adjustment for age, this is also correct. So standardized mortality ratio is not done in direct standardization. It means standardization is of two types, direct and indirect. So SMR, standardized, the question says SMR is a form of direct standardization. No, SMR is done in indirect standardization, and it is calculated by observed death / divided by expected death into 100, and it is done, permits adjustment for age. Yes, correct. So the answer here, except, which is the odd here, is a form of direct standardization. I'll explain this. So first of all, just to remember, SMR is not done in direct standardization. Okay, let's take the fourth question. About, now the question is asking about direct standardization. All are true except, again comes the word except. So age specific death rate is not needed. I'm not sure. I'll cross now. I don't know whether it is right or wrong. Standard population is needed. Yes. Standardization, in direct standardization, we need standard population. Population should be comparable. Definitely you are going to compare. So the population should be comparable. Two populations are compared. Yes, correct. Age specific death rate is needed, not needed. I'm not sure. The answer here is age specific death rate is needed. In direct standardization, you need age specific death rate. So in this question, the answer is A. Don't worry, I'll explain it how. Okay. Now, try to understand the concept of standardization. You are going to compare, for example, crude death rate. Let's take India. And let's take any other country X. I'm not naming any country X. So crude death rate of India as of now, and please remember, crude death rate of India is 6 per 1000 mid-year population, right? So this is the current data. You can quote also 6 per 1000 MYP, mid-year population. And suppose you're comparing any other country X, hypothetically I take, for example, 5 per 1000 mid-year population. By seeing this crude death rate, we can say X is the country which is performing better, health system is better in comparison to India, because India's crude death rate is more in comparison to the other country. But this is, we cannot do, because the population of India, age composition of population of India is different with the age composition of population of the other country. So age will act as a confounding factor. It will influence the result. So to compare this, you need to standardize. You need to do standardization. So in one word, in one line, you need to understand The crude death rate of two cities, two countries, two places cannot be compared because population composition is different. Age can act as a confounding factor. It can influence the result. So we need to do standardization. And standardization can be done by direct way and indirect way. And there is a concept of taking standard population also. One more MCQ point happens here. National population generally we take as standard population, but it is not mandatory. It's not mandatory every time you have to take national population as standard population. So now we'll try to understand direct and indirect standardization. Please focus here. So I'll just go directly on direct standardization, how to explain. Now please try to focus on this slide. I have taken two cities, London. I have taken another city, Camden. I want to compare the death rate of London with Camden, right? London crude death rate is 7.5, it's given here. Camden crude death rate is given 6.5. So if you see students, 7.5 and 6.5, easily anyone can say Camden is better performing than London, right? But again, the question comes, can we compare London with Camden based on crude death rate? Just now I have said, no, we cannot compare because the population composition is different. So what we do now, we take a standard population. We have taken a standard population, which is European population here for London also, and the same European population has been taken for Camden also. The first step done. Right? So standard population has been taken. Now, the population composition, I have divided into class intervals 0 to 4 years, 5 to 14 years, 15 to 44 years, 45 to 64 years, 65 plus. In each age class interval, age specific death rate per 1,000 population in this age group has been given. For example, let's understand. In London, in 0 to 4 year age group, in children, this age group, this 10 means what? Try to understand this. 10 means in the age group of 0 to 4 years, 10 children are dying per 1,000 mid-year population in this age group. This is already given. You need this. Similarly, if somebody asks what is the age specific death rate in 5 to 14 years age group, it is 3.3 per 1,000 population in this age group. Now, the standard population I have already taken, which is European population, the total is 1 lakh, and the class interval, the same class interval, I have broken that, and each class interval population is also is mentioned here, 10,000, 10,000 and all. Now, you have to do certain mathematics. Try to understand, if 10 children is dying per 1,000 population in this age group, please apply this on this 10,000. What do you mean by this? Simple mathematics. In 1,000 population in this age group, 10 kids are dying. So in 10,000, how many kids will be dying? It will be 100. Simple. So this is the expected death in this 100, which is 100 in this European population when we have taken. Similarly, just take another example. In 5 to 14 years age group, how many kids are dying? 3.3 per 1,000. So in 1,000, 3.3, if you apply this age specific death rate on standard population, which is 10,000 again, how many kids will die? 33. Similar thing has to be done for this age group, this age group, this age group. So you have expected death for each age group. If you add this, it becomes 936. So in 936 kids are dying in 1 lakh population, standard population. How many will die in 1,000? That is 9.4. So this is my direct standardized rate for London. Students, we have to do the same thing for Camden. I'll do 1 or 2 for you. So in 0 to 4 year age group, 13.8 kids are dying in 1,000 population. How many will die in 10,000? So it is 138. 3.9 kids are dying in 5 to 14 years age group. How many will die in 10,000? It is 39. So expected death we are calculating for Camden also. We got 1189.5, which is dying in 1 lakh standard population. How many in 1,000? It is 11.9. So DSR, direct standardized rate, for London is 9.4 and for Camden is 11.9. Now, based on DSR, I can easily say London is better performing than Camden. But when I said based on crude death rate, it was presumed it was looking like no, Camden is better performing than London, which is wrong. So this is a way we do direct standardization. So what is the takeoff point from this? Age specific death rate is required. That was the question asked in that question in that MCQ. So you require a standard population, you require age specific death rate, you have to apply age specific death rate on the standard population to get the expected death. So this is the way direct standardization is done. Let's go for indirect standardization. If you remember the question, I said we calculate standardized mortality ratio, right? And let's try to understand with the example, so it will be easy. Now in indirect, so it is an indirect way of standardizing it, right? So what happens here, I have the national death rate in each class interval, 25 to 34, 35 to 44, 45 to 54, 55 to 64, we have the national rate given, national death rate given. So what can I understand from this? I understand that, okay, in the age group of 25 to 34, 3 people are dying per 1,000 population. In 35 to 44, 5 people are dying in per 1,000 population. So this is given. I want to check that the same death rate is in the doctor population, specific group of population. Here the example I have taken doctor. So if the death rate is 3 in means nationally, the same death rate is in doctors or not. Let me check. So in same way we have to do in 1,000 population, 3 people are dying. So how many will die in 300? So obviously in 1,003, so in 300 it is 0.9. So expected death in doctors is 0.9 in this age group. 35 to 44 years, 5 people are dying in 1,000. So how many in 4? 400. So it is 2, right? Similarly, if we calculate the expected death in doctor population, so and when we add this, it becomes 7. We have already got this data of observed death. Reality death in doctors is 9. The expected death is 7. So if you remember the formula, I said that time standardized mortality ratio is observed death oblique expected death. Observed death is 9 and the expected death is 7. So the value is more than 1. So this is the way you have to calculate standardized mortality ratio. So I'll summarize this. What you have to do, the national rate data is given. You have to apply that on specific group of population. In this example, I have taken doctor's population. So you're applying on the doctor population to calculate the expected death. So you have the expected death, observed death is already given. So observed death oblique expected death, you calculate. If the value is more than 1, please remember, if the value is more than 1, risk of death is more in study population. And in this example, the study population was doctor, right? So if the value of SMR is more than 1, the risk of dying is more in the study population than standard population. So this is the way to understand indirect standardization. I hope this is clear with the example. Okay, let's go with the 5th question. Now, which of the following statement is not true? Please, just the moment you come with such questions, no, not true, except, you need to be more focused. So let me identify which all are true. Prevalence increases when a drug in program is effective. I'm not sure about this. I'll put a question mark. Incidence implies number of new cases detected over a fixed time. Oh, I know this, that incidence means new cases over a period of time. So this is correct. This is not true. This is correct. Okay. Vaccination strategies decreases the incidence of a disease. Yes, if you are giving, measles, mumps, rubella, so the cases of measles, mumps, rubella comes down. Okay, so the incidence decreases. This looks correct. Newer and effective treatment. You have a good treatment, new treatment, that will definitely decrease the prevalence. Yes, this also looks good. Let me go with the first. So this 3 looks good. Can we see the first one again? Prevalence increases. So he's saying prevalence will increase when the drug in a program is effective. So when we have a good drug, effective drug, it will cure the disease. So prevalence should decrease, not increase. So in this question, this is incorrect, right? So the answer is A. Let me take one more question on this sort of questions. A drug which reduces mortality. Stop here. There is a drug which reduces mortality. Means the drug is effective, it's not letting the patient to die, but does not cure a disease. Now there is a catch. The drug is saying, or means the drug can reduce the mortality, it will not let the person die, but at the same time it is not curing also. So what will happen? Incidence prevalent both increase, I don't know. Incidence prevalent both decrease. Incidence increases while prevalence decreases. Incidence same, prevalence increases. So to understand this, the answer here is D. Incidence remains same, prevalence increases. I'll just explain this with a simple box, and then this will help you to solve all such questions. Whenever this incidence prevalence question comes, which increases, which decreases, what will happen to increase, what will happen to incidence and prevalence, always think with this. Whenever such question comes, take a box, right? Take a box, make it as a prevalence box. This is my prevalence box, right? Now what happens? New cases comes from this side, no? So I am representing new cases with tick. So somebody gets infected, develop disease, so it will come inside this prevalence box. There may be already people who are suffering from disease, which I am representing with X, right? So there are new cases, there are already existing cases. Now, so this box, so one way of increasing the number in the box is please put more cases inside. No? Please put more cases. So incidence increases, prevalence will increase, definitely. Now, there are two ways of exit also. One way of exit is cure. I have a good drug which is treating the patient, so patient is coming out. Patient gets treated. The other way of reducing this box is death. If the person dies, if the disease is very fatal, the person dies, so the person will be out of the box. So this prevalence box is regulated by new cases. If this increases, this will increase. If death increases, box will decrease. If cure increases, box will decrease. If cure decreases, box will increase. If death decreases, box will increase. Right? So the question was, if you remember the question, you have a new drug which is not letting the patient die. Patient is not dying. The drug is good enough to reduce the mortality, but it is not curing also. So it is letting this box, the person in the box only. So this box will increase. So prevalence will increase. Incidence remains same because incidence has to do nothing with this box. Incidence has to do with the infection. If the person is getting infected, so he will develop the disease. So whenever such questions comes, incidence, prevalence, what is going to increase, what is going to decrease, the best way of understanding is this. This prevalence box is regulated by incidence, regulated by duration also, which we all know. We read in a community medicine P into I into D, and also death and cure. So if this increases, cure is this will decrease. If this decreases, this will increase. If this increases, this will decrease. If this decreases, this will increase. Simple. Okay, I hope it is clear now. Now, let's go to the next question. Which of the following is used to estimate relative risk? Please remember, relative risk is used for cohort study, right? In case control study, we uses odd ratio. So in cohort study, we use relative risk, right? Okay. Now, this is a question on odd ratio. So two things will happen with this question. Once I solve this question, it will clarify the concept of order ratio. It will also help you to understand case control study in a simplest way. And it will, any questions related to order ratio, you will be able to answer it. Right? Now, please read the question. In an investigation to study the effect of smoking on renal cell cancer. First of all, whenever such question comes, so I have read the first part of the question. So the disease in this question is renal cell cancer. Okay. So it is definitely a case. So it looks like a case control study. Okay. So in an investigation to study the effect of smoking on renal cell cancer, it is observed that 30 of the 50 patients, okay, so I'll write here 50 patients are there, in which 30 are smokers. Question is 30 of the 50 patients are smokers, as compared to 10 out of 50 controls. So we have 50 control also. In this, 10 are smokers. The question has given this, right? So in 50, 30 are smokers means 20 are non-smokers. Simple. In this 50 control, if 10 are smokers, means 40 are non-smokers. So this is the information which we can draw from the question. They are asking me to calculate odd ratio. Now, this is my case, this is my control. Now, in simple terms, if I ask you, what is the odd thing happening here? Odd thing is smoking. Nobody wants, smoking is not a normal habit. It is not considered as a normal habit. So the odd is 30. So what is the odd in this 50 cases? 30 out of 20. These 20 people are not smoking, so they are not odd. These 30 are smoking, so they are odd. So odd in case happens to be 30 out of 20. What is odd in control? 10 out of 40. So odd in control is 10 out of 40. So we have to take odd ratio. What we do in this, we take odd ratio in cases, which is 30 by 20, and we take odd in control, which is 10 by 40. If you calculate this, this becomes 6. Answer will be 6. So here the answer is 6. Now odd ratio is also called as cross product ratio. Now generally students are very familiar with cross product ratio. Students, in whatever way you do, ultimately you will be correct. But the only thing is that you have to interpret the question correctly. Let me explain here by doing by the same solution I'll do with by using cross product formula, AD into BC. Let's see. Let's put anything in column, 50 cases, 50 control. Let's take smoking. Let's take non-smoking. So in 50 cases, 30 were smoking, 20 were not smoking. In 50 control, 10 were smoking, so 40 were non-smoking. So you can do cross product, do 30 into 40, 10 into 20, you see, 6. I'll just put this one here now and this one here now. See, 50 cases, 50 control, 30 were smoking, 20 were not smoking. 50 controlled, 10 were smoking, 40 were non-smoking. Again you do same, 30 into 40 divided by 10 into 20. Answer is 6. So in whatever way you do cross product, or you understand the concept, the way I have explained the first one, in any way you do, the answer will be 6 only. So this is the way to understand odd ratio. Okay. Yeah. Now let's go to the question number 9. Now in this question, if you see, in a study 200 smokers, okay, so there are 200 smokers. So the study starts with exposure, and there are 600 non-smokers. Were followed up, so they are being followed up for a period of 10 years, right? 10 years. So when you are following up for a period of 10 years, so this is a classic example of cohort study which is prospective, right? You're following for a period of 10 years. So you followed for a 10 years. Out of this 200, 60 developed hypertension based on the question information. And out of this 600, 30 developed hypertension. Now here also you understand, what is this 60? This 60 is incidence in the exposed group. And what is 30? 30 is incidence in the non-exposed group, which is 600 non-smokers. So cohort study, incidence develops, and cohort study also help us to understand natural history of disease. This is also asked in MCQ question also, right? Now the question is, they're telling us to calculate risk ratio. Risk ratio is also called relative risk. Now please try to understand the concept. No formula is required. One, we know relative risk is equal to incidence in exposed out of incidence in non-exposed, right? Exposed divided by non-exposed. Okay, this is fine, but let me understand the basics. If I ask you in simple terms, if 200 people were smoking and over the period of 10 years, 60 developed hypertension. So what is the incidence rate? So you will say 60 by 200, obviously. And this you can express into 1000 also, because incidence are generally expressed in 1000. I'm not going into that. In 600 non-smokers, 30 developed hypertension. So what is the incidence rate here? 30 by 600. So now you have to only tell us that the incidence in comparison to smokers and non-smokers, what is the risk? Where is the risk more? Obviously, with the simple data I can see, in 200 people, those who are smoking, people developed hypertension is 60. And those who are not smoking, the number of hypertension is less. So in comparison to non-smoker, the development of hypertension in smoker is more. So how to check that? Take the ratio. Take the ratio, you will get the answer. So 60 by 200 divided by 30 by 600, if you do, the calculation will be 6. And what is 60 by 200? It is incidence in exposed. What is 30 by 600? It is incidence in non-exposed. So this is the formula. So the answer is 6. If relative risk is greater than 1, positive association. If relative risk is equal to 1, no association. If relative risk less than 1, negative association. Please remember. Here the answer is 6, means probability of developing hypertension is 6 times more in those who are smoking in comparison to those who are non-smoker. So the answer is 6. Okay. Let's take the next question, question number 10. And this question is not only going to help you to calculate population attributable risk, but this will also help you to understand the overall concept. And I have kept this question deliberately so that you understand this question also, and you understand incidence, relative risk, risk difference, attributable risk, population attributable risk, everything in one question. So which helps you to solve everything related to such questions if it is asked. And whenever you are solving such questions or you are trying to understand, don't be very much dependent on formulas. It helps you to calculate very easily. Try to understand this. Now, 100 individuals are diagnosed with lung cancer. Okay, so the disease is lung cancer. How many people are dying here? Diagnosed is 100, right? 100 individuals are diagnosed with lung cancer. Okay, population is 1 lakh. Okay, so I write here population 1 lakh. Okay, out of 100 patients, 80 were smokers. So if I break this, 80 smokers. So what will happen to this 20 now? Or you can say, oh, these are non-smoker. And 20,000 were smokers in total population. So they are also giving the information that 20,000 are smokers. So what is 80,000 then? It is non-smoker. They are telling us to calculate population attributable risk. We will calculate that also, not a problem. But I'm trying to understand here everything. Now, please try to see. So, how many are smokers in the population? 20,000. How many are non-smoker? 80,000. In this 20,000, 80 were smokers. 20,000, 80 developed lung cancer. And in 80,000, 20 developed lung cancer. This is the question, information given. So if I ask you what is the incidence in this group, what you will do? 80 by 20,000. What is the incidence in non-exposed? You will say 20 by 80,000. So if you take the ratio of this becomes a relative risk. Simple, right? So this is the way you calculate relative risk here. If somebody asks you, no, okay, relative risk, what is the attributable risk? So if I calculate here, let me calculate also for you. By 20, so this is 4, this is 4. So it is 16. So my relative risk here, let me write here, is 16:1. Means 16 by 1. 16 times more probability of developing lung cancer in those who are smoking. But the question is not asking us to calculate relative risk. If I ask now, can you calculate, risk difference? To understand risk difference, try to understand the 16:1. So 16 people will develop lung cancer since they are smoking, but this one gentleman is also developing lung cancer, but they are not smoking. So this 16 people can ask this one gentleman, we smoked, we developed lung cancer. We did a wrong thing, we developed lung cancer. You did not do anything, why did you develop lung cancer? So it means there is some other factor also responsible for that. So if this 16 people, imagine they would have not smoked, then also one person may have developed lung cancer. So what is the risk difference? 16 minus 1, which is 15. So out of 16, definitely 15 is attributed to smoking. So 16 minus 1 is called risk difference, and 15 out of 16 by 100 we are doing, this is attributable risk. And what is the attributable risk formula when we learn? We say incidence in exposed minus incidence in non-exposed out of incidence in exposed into 100. So this incidence in exposed is, 16, incidence in non-exposed is 1, and this is 16, we have calculated, so we got 15 out of 16 to 100. So roughly around 93% is the attributable risk. Attributable risk means, what is 93%? How to understand that? If I remove smoking as a risk factor, I will be able to reduce lung cancer in exposed group by 93%. So we have understood attributable risk, but the question here was PAR, population attributable risk. So in population attributable risk, I'll take a next slide so that it becomes easy for us to understand. We have to calculate incidence in population. If you remember, the population was 1 lakh, and how many people developed lung cancer? 100. So out of 1 lakh, 100 people developed lung cancer. So what is the incidence? Incidence is 1 per 1,000. Right? This is the incidence in population. Now, what is incidence in non-exposed? If you go back in the slide, incidence in non-exposed were 80,000 people who were smoking, who were non-smoker, and 20 developed lung cancer. So it is just 20 by 80,000 into 1,000. So it is roughly around 1 by 4. So what is population attributable risk? I am saying the incidence in population is 1, incidence in non-exposed, these people were not smoking. So I have to remove this from this. So what I'll do, 1 minus 1 by 4 out of 1 into 100 when we do, which is 3 by 4, which is 75%. Put the formula. What is 1? Incidence in population. What is 1 by 4? Incidence in non-exposed. What is 1? Incidence in population, and you are taking percentage. So this is your population attributable risk. The answer is 75%. Now see all the indicators. Relative risk was 16:1. Attributable risk was 93% approximately. PAR is 75%. What do you mean by this? You mean by this is those who are smoking 16 times more probability of developing lung cancer than in non-exposed group. What is 93% here in attributable risk? If you remove smoking as a risk factor from the exposed group, you'll be able to reduce lung cancer by 93% in the exposed group, not in the population. This 75% which you calculated as population attributable risk is, if you remove smoking as a risk factor, you will be able to reduce lung cancer in the entire population by 75%. So as a public health expert, for us, the best indicator is population attributable risk, because it helps you to solve the problem of entire population. It is not helping you to solve in the population of only exposed group, right? So the summary is, relative risk is equal to, if I put all the formulas together for your better understanding, incidence in exposed out of divided by incidence non-exposed, that is the ratio. Risk difference is equal to incidence in exposed minus incidence in non-exposed. Attributable risk is risk difference out of incidence in exposed into 100, which in the books it is written incidence exposed minus incidence in non-exposed out of incidence in exposed into 100. It's 100. And PAR is incidence in population minus incidence in non-exposed out of incidence in population, and just you are expressing into percentage. This is the things which you need to understand, and these are all related to cohort study, right? So this will help you to solve all the questions. Okay, let's take the 11th one, and if you've understood this, this question will be solved very easily. If we want to calculate reduction in disease by modifying risk factors, I want to modify the risk factors in the population, irrespective of smoking or non-smoking. Which parameter can be calculated? Which is the best one? Now, based on the previous discussion, the answer should be population attributable risk, because this helps to solve the problem of entire population. This is incidence, this is relative risk, attributable risk. This is only focused in exposed group, but this focus in the entire population. So my answer goes to D. Okay. Okay. Now let's take the 12th question. Confounding can be removed by. How can you remove confounding? Assign confounders equally to both cases and control. Randomization, matching, all of the above. Now, please understand what is confounding, and the best way of understanding is so that it will be able to help you to solve the question also. So let's take, I always give this example, coffee with sugar. There was a classic example given when there was a study which proved that excess coffee with sugar leads to MI. Now the moment you see these students, you will say, okay, if I am taking lots of coffee with sugar, whether this will lead to MI, now everyone will stop taking coffee with sugar. So then there was further, studies and details. So is there something wrong in the study? Then what we found, it was found that those who were taking coffee with sugar were also smoking. So this variable was not considered when the inference was made. Now smoking is associated with this. Smoking is also associated with this. Now this is a variable which is associated with the exposure. It is also independently, and it is also associated with the outcome also. So smoking acts as a confounder here. Smoking is a confounding factor which has indirectly affected the result which we were not aware. right? Which is a spurious association, which is a wrong association I'm trying to make. But this is the way to also understand what is confounding. So smoking is a confounding factor here. So how will you remove this confounding? See, so you are assigning equally to both cases and control. You're trying to be not biased. Both cases and control, you're assigning equally confounders. Randomization, you are unbiased. Randomly you're picking, so you cannot be biased. Matching. Remember, matching is done in case control study. Suppose there are cases, right? Okay, just wait. Cases. So you want to take control. You want to select control. So what you do, you match. You match all the features of cases with all the features of control except one. You try to match everything possible except one which you don't want to match, and that is disease. You don't want that this person is suffering from disease, so the control will also suffer from that disease. The moment the person suffers from the disease, he or she cannot be controlled. So what you have to do, you have to try to match. So matching is done only for things which you know. I can match when I know something. I cannot match when I don't know anything. So matching helps you to remove known confounders, which you are aware of. So matching can help you to remove. So all these factors helps you to remove confounding. So the answer here is all of the above. Okay. Yeah. Matching can be removed by randomization, restrictions, matching, stratification, and definitely statistical modeling. These are all the ways where we can control confoundings. Right? Okay. Now let's take the 13th question. Now the government plans to outline tobacco control laws, right? So government is trying to strictly implement, execute tobacco control laws. What is the level of prevention here? What level of prevention it is going to do? So primordial, primary, secondary, tertiary. So the answer is primary prevention. I'll explain this. Okay. Because there are lots of questions asked on this. Let's take another one. Hand washing during COVID-19 is what level of prevention? You're doing regular hand washing we used to do COVID, and that has been a habit now also. So what level of prevention we are trying to do? We don't want to get COVID-19. So it is a specific protection. I don't want to get infected. So it is also doing a primary prevention. Wait. Okay, let's take the 15th one. The government deciding to leave certain fishes in water bodies to control malaria. So government is trying to leave that gambia fishes so that they can eat the mosquitoes and all. So what level of prevention is this? This is primordial prevention. Please be specific. This is primordial, right? How? I'll explain. Let's take one more question. Annual Mass Drug Administration. You are doing annual mass drug MDA, which is done in filariasis. So what level of prevention is this? Is it primary? Yes. Is it secondary? Probably yes. Is it primordial? No. Can it be primary and secondary both? Yes, it can be primary also. It can prevent people who are not suffering from the disease. It can also help in those who are diagnosed early for secondary level prevention also. The answer is C. Okay. Now, the level of prevention you have to understand. And I'll take certain examples to make it more clear. But these slides help you to understand everything. So this is my natural history of disease. If you remember natural history of disease, it starts from period of pre-pathogenesis and period of pathogenesis. Now let's match this natural history of disease with level of prevention. So in pre-pathogenesis, the onset of disease means the agent has not entered inside human being. At that point, primary prevention can be done. So in period of pre-pathogenesis, primary prevention can be done. And in primary prevention, what is the mode of intervention? How can you intervene? You can do health promotion. You can specifically protect. Now health promotion, so nature of measure is promotive, and specific protection is you are trying to prevent. For example, you are giving sex education. You are telling to take adequate nutrition. You're telling about breastfeeding, you're talking about family planning, you're promoting things, health promotion. Primary prevention can be done in pre-pathogenesis. Now I want to immunize against TB. You're giving BCG vaccine. So BCG vaccine is preventing against TB. You are using condoms to prevent STD, AIDS and AIDS. You're giving vitamin A prophylaxis. You're specifically protecting. You are driving a two-wheeler. You are wearing a helmet from road traffic accident. So these are specific protections. But again, it is a part of primary prevention. Now let's try to understand. The disease has entered inside the human being. So period of pathogenesis. How can you prevent now? You can do secondary prevention. You can do tertiary prevention. In secondary prevention, what is the mode of intervention? The disease has started in the human being now. What you will do, you will try to diagnose the disease early. Let me identify the disease early so that early treatment can be done. What helps you to early diagnose? Screening. Screening is done in secondary prevention. Screening helps you to diagnose early so that early treatment can be done. But once the disease has progressed, so you cannot do anything now. You can only limit the disability. So disability limitation, and the disease has progressed to a certain extent that you can only rehabilitate. So these two mode of intervention is a part of tertiary prevention. In disability, you are restorative. You're trying to restore whatever is left. You're trying to limit the disability. But in rehabilitative, you are only providing support now as a rehabilitative measures. You cannot limit the disability now. So promotive, preventive, now you're trying to primary prevention, period of pre-pathogenesis, mode of intervention, health promotion, specific protection. Period of pathogenesis will have secondary and tertiary prevention both. In secondary prevention, you do early diagnosis and treatment, which is screening. And tertiary prevention, you do disability limitation and rehabilitation. Now let's try to understand with quick examples. Now let me give you an example. A patient with fever and cough with greater than 3 weeks comes to DOTS clinic for sputum for AFB. What is this? What level of prevention is this? Patient is having fever with cough, right, 3 weeks, and comes to DOTS clinic for sputum, for testing of sputum. So what will happen? You are doing diagnosis. What type of diagnosis? Early diagnosis. So what level of prevention? Let me take. So mode of so we'll answer into two concepts. MOI, mode of intervention, and LOP, level of prevention. So this patient who is having fever and cough for greater than 3 weeks and came for sputum for AFB. So what level of you are doing early diagnosis? This is MOI, mode of intervention. And what level of prevention is? Remember that table which I showed? Secondary level of prevention. Let's take one more question. Yeah. A patient with sputum positive for AFB. The person is already diagnosed with AFB. Diagnosed, categorized as drug sensitive TB under NTEP, and you are giving intensive phase treatment. The person has been already diagnosed as TB. Treatment has started. So what level of prevention you are doing? Secondary prevention. What is MOI? Since you are giving treatment, so it is treatment. So in secondary prevention, if you remember what we used to do, early diagnosis and treatment. So here we are doing treatment. So secondary level of prevention and mode of intervention is treatment. Let's take one more example. A patient with fever and chill comes to malaria clinic for peripheral smear for malaria parasite. So coming for diagnosis, so level of prevention is secondary, mode of intervention is early diagnosis, right? Let me take one more example. Patient with fever and chill comes to malaria clinic and was given a treatment, presumptive treatment. So level of prevention is secondary, mode of intervention is treatment. Now a person sleeps inside a bed net. So the person is protecting himself or herself from mosquito bites. So this is what? Specific protection. You're protecting. So this is a specific protection is a mode of intervention. What level of prevention is? Specific protection is a part of primary prevention. Let's see the answer. Yes. So we are doing specific protection and primary level of prevention. Let's take one more. A child coming to immunization clinic for OPV vaccine. So you are giving OPV vaccine to prevent against polio. So you are again doing specific protection, and the level of prevention is primary. Okay. Now, a urine strip for sugar detection was employed to screen diabetes in a community. You are screening diabetes by using a urine strip sugar. So what level of prevention? Secondary prevention. What is mode of intervention? Early diagnosis. Right? Let's take one more. Village community was given health education to prevent spread of malaria. You're giving health education. You're promoting something. So primary prevention is my level of prevention, and mode of intervention is health promotion. Okay. Now, a 20-year-old male take chemoprophylaxis during epidemic of meningococcal meningitis. So there was an epidemic of meningococcal meningitis. So I am taking a chemoprophylaxis. What are you doing? You're not suffering from any disease. So this is primary prevention, and mode of intervention is specific. You're taking a prophylactic treatment just because you want to protect yourself from meningococcal meningitis. So this is specific protection, and level of prevention is primary level of prevention. Now, a class of 5-year-old children is discouraged from adopting harmful lifestyle. I go to a 5th standard school and I say that don't smoke and everything, smoking is not good for health. I talk about harmful lifestyle. So what level of prevention is this? This is students primordial. Please try to understand how it is primordial. What is primordial prevention? Prevention of emergence of risk factors. You don't let the risk factor to emerge. So a 5th class student is not aware much about smoking. He doesn't understand much. So you are giving information about smoking and harmful lifestyle. Why? Because you want that this student should understand now, and the risk factors should not emerge. So in subsequent years, when he grow adult, he understands the concept and he doesn't start smoking. So this level of prevention is called primordial prevention, right? Now, a child afflicted with poliomyelitis, the child is suffering from polio. You are given crutches to walk. What have you done? The child is already suffering from poliomyelitis, he cannot walk. You are given crutches to walk. So the level of prevention is obviously disease has progressed to advanced stage. It's tertiary level of prevention. What can you do now? You have only given crutches so that you can rehabilitate. So this is rehabilitation, right? Okay, so these are the different ways of understanding primordial, primary, secondary, and tertiary. Let's take the next question now. A 35-year-old man is unemployed. The person is unemployed because he is unable to walk. Okay, person cannot walk, so he is not getting any job, so he is unemployed. So his unemployment is classified as, how do you classify this? Is it disability? Is it handicap? Is it disease impairment? Now the answer here is handicap, right? I'll tell you why and how. If such question comes, what is the basic understanding? What is the concept? Now try to understand. If I'm suffering from disease, suppose a person met an accident. So obviously accident means what will happen? The person normal status will be deviated and will suffer from something. So he'll be deviated from normal. So some pathology will happen. He'll lose food, he'll had a road traffic accident, head injury, anything can happen. So in this example, I'm trying to make you understand if something is going wrong. So accident here is equivalent to disease. So if someone has suffered from an accident and he lost a foot, for example. So if he lost his foot, so he has lost the anatomical structure. If something goes wrong in accident, I lose my voice also. I cannot speak. So I am not able to speak. So I am losing some physiological thing, anatomical thing. I'm not able to. So in this example, the person is not able to walk. Why? The person has lost foot. So anatomical structure is lost. So that is impairment. Just because of the disease, accident here, the person lost his foot, which is loss of anatomical structure. So he lost his foot. So this is impairment. Just because he lost his foot, the ability to walk, a normal person will walk because he has got a foot. This person will not walk because he hasn't got his foot. He has lost his foot. So the ability to walk is now he cannot walk. So that becomes its disability. Ability, the only word we have to add, disability. He cannot walk now. Now if he cannot walk, what has happened? The job requires walking, the job requires to stand, job requires to move from one place to another. The company has fired him, the company has removed him. So this is unemployed. Now what has happened? He has lost his job just because of the disability. So this is handicapped, right? So this is the way you understand. So disability is the ability which a normal person must be doing, is doing. I can walk, you have suffered with an accident so you cannot walk. So that is disability. And since you are not able to walk, you have been fired from the country, you lost your job, you are unemployed, right? So unemployed is handicap. So this was the question asked there. Okay, let's take the next one. All are correct for Human Development Index except, now again I said whenever this except comes now, please be watchful. Life expectancy at birth, yes. Life expectancy at birth is a part of HDI. So I have to only find except. International comparison. We compare, all the countries are compared, which country is at which point, India is at which point. I'll give you the latest information which will be helpful for your exam also. Income. Human Development Index depends upon 3 factors. Longevity, which is life expectancy, knowledge, which is your education, and income. Every country's income is compared, right? And the third one, and so income is also required. It's correct for HDI. International comparison is also important. Life expectancy at 1 year of age is a part of PQLI, Physical Quality of Life Index. It is not a part of HDI, Human Development Index. So answer is B, life expectancy at 1 year of age. Okay, let me take one more in question, then I'll go with the explanation. Which of the following demographic indicators is used to compare life expectancy of 2 different countries? I want to compare life expectancy of India with life expectancy of Japan. So which indicator will help you to calculate? Obviously it is HDI, Human Development Index. Okay, now please try to understand this and please use this data because this is the real data, updated data. Now, as I said, there are 3 dimensions. First is health, right? Where we take the indicator is life expectancy, longevity, which I said. Second is education, which has got 2 sub indicators, mean year of schooling, expected year of schooling, and then you have standard of living, which is compared on purchasing power parity in real gross national product per capita. So how do we calculate? We take a maximum value, we take a minimum value. So life expectancy maximum value 85, minimum value 20, mean year of schooling 15 and 0, and expected year of schooling 18 and 0, and GNP 75,100. So these are the values which we need to remember. Current status of India, please. This is for 2020, 23 and 24, which is not in the books also. Life expectancy in India as of now, current data we are using is 67.7. What do you mean by this? You mean that on an average in India, people are surviving till 67.7 years. Mean year of schooling, average year of schooling in India is 6.6. Expected year of schooling, right? It is 12.6. Maximum is 18. 12.6 years is the expected year of schooling. And real GNP of India is 6951. Based on this, HDI, which we calculate from 0 to 1, so India's values is 0.644. Please quote this value. It is a current HDI report. India ranks 134 out of 193 country. In the books you may see 130, 129 somewhere, 132. But the current data says India ranks 134. The top country is Switzerland with HDI 0.967, and bottom country is Somalia, which is the bottom country, which is the HDI has got lowest one, right? So please use this Human Development Index data. This is the current updated one. Okay. Now, which of the following indicator is the best to know the overall burden of disease? I want to understand the overall burden of disease. The best data is DALY, disability adjusted life years, quality adjusted life years, health adjusted life expectancy, disability free life expectancy. All these are things. Well, I try to explain this. But DALY is the indicator which helps to understand burden of disease. It's the best measure. Why? Because in simple terms, if somebody asks you, students, and if you don't remember the technicality of DALY, forget it. DALY measures in one term mortality plus morbidity. And in morbidity, I'm writing here disability, not to get confused. Disability is also part of morbidity. So DALY measures mortality and disability. So one indicator which gives you both the component, how many people are dying, how many people are disabled or morbid, right? So this is the best indicator. Now try to understand what is DALY, because this question is very important, and on an average, this one or two questions are asked. Just a second. DALY, as I said, mortality, morbidity, in the bracket I am writing disability because the word goes disability adjusted life years. So it measures mortality and disability. So what is mortality? Death. What is morbidity or disability? Suffering from disease or any disorders. So DALY measures death, DALY measures disease. Both is combined in DALY. Okay, try to understand this. Now you have DALY. LY is life years. So LY is related to mortality. Means, suppose India's life expectancy, just now I have said 67.7 years. Suppose any person dies at 50 years. Suppose, just an example. So how many life years he lost due to this premature death? What will you do? 67.7 minus 50, which is 17.7 years. So this person has lost 17.7 years due to premature death. So this is my LY, one component. Second one is DA, disability adjusted. So disability adjusted, how we adjust? We take disability weight, where we take range from 0 to 1, where 0 is fully healthy. Please remember, we start from 0, which is fully healthy, and 1 is 100% disabled. The moment you reach 100% disabled means you're dead. So you have to give disability weight in between 0 to 1, and then you have to adjust the disability, because you writing disability adjusted. So how you adjust that? You multiply this disability weight, which is 0 to 1, by duration of illness. Let me explain this by an example and try to understand this. If you understand this, everything will be easy for DALY. Now, take a person who is born here. The blue bars are that this person was in good health. He was not suffering from any disease. The red bars are when the person was suffering from certain disease. He was morbid, he was disabled due to, and he got treated. Then again, so suppose the person is normal here. He got sick here, again he is normal, again he got sick, again normal. This happens in our life. We become sick, we get treated, and it goes on. It goes on. In this example, the person was expected to live till 65 years, but the person died at 50 years. So if I ask you LY, life years lost due to premature death, simple, what you will do, 65 minus 50, which is 15 years. So you lost 15 years due to premature death, right? Okay, so this is mortality component, one component, LY component. What is disability adjusted? So I'll take all these red bars, red bars, where the person was morbid, disabled. I said disability adjusted, just now I have discussed, was, you have to multiply by disability weight into duration of illness. So let's take this example. The person was morbid for 2 years here, and the disability weight given was 0.5. So what I'll do, 0.5 into 2. Here the person, again the person got treated. Now what happened? Here again the person got sick for 1 year and the disability weight was 0.2. So 0.2 into 1. Again the person got sick for 5 years and the disability weight was 0.6 this time. So you multiply 5. Again here for 2 years, 0.3. So 0.3 into 2. So can you multiply all this and can you add this? I have done here for you, right? So 0.3 into 2, this is 2, not 1. Even if it is 1 also, if I put here, but you have to add this. So this, whatever you get, this is DALY due to morbidity. The person is not dying, the person is only sick. But the disability adjusted, you have given disability weight, you have taken the duration of illness, and based on that you have calculated DA. So that is 4.5 here. So if you now add 15 plus 4.9, 19.5 DALY. And 1 DALY is equal to 1 year. So this person lost 19.5 years. 15 years due to premature death and 4.5 years due to disability or morbidity. So DALY is an indicator which measures morbidity and mortality together, right? Now, can we derive the formula for DALY? DALY is equal to year of lost life due to mortality, as I have explained, and year lost due to disability, 4.5 years, which is due to disability. So this you both add, you get DALY. 1 DALY is equal to 1 year of healthy life lost, and it is the best measure to know the burden of disease. There was one more terminology there, QALY. QALY is just opposite to DALY. DALY talks about burden of disease, how many people are dying, how many people are diseased. So it talks about the negative things. QALY talks about quality, good things. So it measures quality and quantity of life. How much good health you are having. No, years of life lived in perfect health. So what is the value of money for medical? Nobody is immune. Everyone will suffer from certain disease. So the intervention which we are doing to treat it so that I can live better quality of life. So QALY measures that, right? Now try to understand with this simple example. I'll take this. Suppose I am suffering from certain disease, right? And I am taking a treatment. Why I am taking a treatment? Because I want to be cured. So the old treatment is helping me to increase my length of life by 2 years. And in quality of life here, we give range from 0 to 1. Just opposite to disability adjusted, there we disability weight, we give 0 to 1 there also, but that is in opposite sense. Here 0 means dead and 1 means perfect health. So I am suffering from disease. I am taking an old treatment. This treatment is helping me to increase my length of life by 2 years. And my quality of life is 0.75. So my number of QALY is 2 into 0.75, 1.5 QALY. Now I have a new treatment. The new treatment is much better than the old treatment. This has increased my quality of life from 2 years to 6 years. I can live till 6 years with quality. And my quality of life is also 0.8 now, moving towards perfect health. So 6 into 0.8 becomes 4.8 QALY. So when I take new treatment, my QALY increases from the old treatment 1.5 to 4.8. So why will I go with this? Let me go with this. So net gain in QALY is 3.3. So QALY measures the intervention, value of interventions. Which treatment you should take. Obviously anyone will go with this. Why will they go with this when you are only increasing 1.5 QALY? So what is the difference between DALY and QALY? DALY measures burden of disease. QALY measures clinical intervention, the treatment which you are giving, how worth it is. This measures the bad part of the life, no? Death, disease. this talks about good of quality of life. In Delhi, 0 was perfect health, 1 was death. In Quali, 0 is death and 1 is perfect health. This is just a slight difference between Delhi and Quali. They are both opposite to each other. Okay, let's take the 21st question. Now, let's see what is the question saying. In a 6-membered family, there are 2 parents. Okay, let me write here, 2 parents and 4 children. Okay, 4 children, all aged between 2 to 6 years, right? One of the children, so I have 4 children, right? One of the children is completely immunized. Okay, completely immunized. So what about the remaining 3? This is 1. Where other 3 siblings are unimmunized. Okay, they are unimmunized. On 12th August, one of these 3 got measles. One got measles. So we are left with 2 now. And the next part of the question is that 2 other siblings also got, these 2 also got measles by 18th August. They're asking you what is secondary attack rate. Now, please remember, in secondary attack rate, primary case is not included in numerator, neither it is included in denominator. First thing, please remember this. Whenever you are trying to understand secondary attack rate, don't include primary case in the numerator, don't include that in denominator also. So in this question, the first child developed measles on 12th August. This is my primary case. Just because of this primary case, these 2 kids also developed measles on 18th August. So secondary cases are 2. So 2 out of 2 into 100. So my secondary attack rate is 100% here. I have not included this in numerator. I have not included this in denominator also. So my answer is 100, right? I'll also explain here one thing. Generally in the questions what it is given, if I change the question, out of 4 child, all are unimmunized. All are unimmunized. 1 developed measles on 12th. I'm changing the question. So I am left with 3 vulnerable child. Out of these 3, 2 developed on 18th August. So I am left with 1, it is vulnerable. So what is secondary attack rate here? So secondary attack rate here, this is my primary case. This will not be included first. So this is my vulnerable population. Out of this 3, 2 developed measles. So here will be 2 by 3 into 100. But in this question, the existing question, it talks about, out of 2 or both developed measles. So 2 by 2. So the answer will be 100%. So don't get confused. The only thing we have to remember is primary case is not a part of numerator, neither it is a part of denominator. Infectivity is also known as. So if you have understood the previous question, 1% primary case, then you are getting secondary cases and secondary cases. So infectivity is best understood by secondary attack rate, right? Now, all this small terminologies, I will explain in simple mathematical way. Infectivity, what do you mean by that? Out of those people exposed, how many people developed infected? Out of people, suppose there are 50 people exposed, 30 got infected. So this is my infectivity. Now, out of those infected, which is 30 in my example, how many developed disease? 50. So this is my pathogenicity, right? So you can understand from here we have taken this. Okay, out of 50 exposed, 30 infected. Out of 30 infected, 50 developed disease. So out of 15 who developed disease, how many are in serious condition? 5. So this is virulency, right? Okay, now out of 5 who are in serious condition, 2 died. So what is this? Case fatality. So you can see this can be linked. So out of how many people exposed, how many developed, how many people are infected, that is infectivity. Out of those infected, how many develop disease, that is pathogenicity. Out of disease, how many are serious disease, that is virulency. Out of serious condition, how many people are dying, that is case fatality. And what is communicability? How the disease spread from infective to susceptible host. One more thing, this incubation period, latent period, generation time, serial interval, all these questions means looks like very much similar, but we'll try to understand with this thing, and anyone can understand based if they can follow the bars and they follow the lines, it will be very easy. So the person here is infected, right? The organism entry has happened. Now it moves, I'll draw here, it moves. What is shown here, till this point, the period is asymptomatic. The person is not aware whether he has been infected or not, no symptom, sign and symptom. But from this period, the person can spread the disease. I am infected. I am not aware whether I am infected, but I am in a capacity now to spread. So till this part, entry of organism to the start of infectious period, this is my latent period, right? Then again we moved, then this person developed disease here. How? Because the person started exhibiting sign and symptom. Oh, am I suffering now? I am having fever, I am having cough, difficulty in breathing. So entry of organism till you become infectious, you are spreading you can spread, but you are not having sign and symptom, that is latent. Further moving up, now you are exhibiting sign and symptom. So this is my incubation period. Now I have sign and symptom. Now this also becomes primary case. So now this is the first case. The person is infectious. The person started showing symptoms. Infectious. Now what happened? This person is spreading the disease to the second person now. The second person will also follow the same thing. He will also have the infectious latent period. He will also develop incubation period. The second person is developing case here. So this is my secondary case, right? So it's for secondary case also, you have your latent period, you have your incubation period, you have your asymptomatic period. Now, the gap between primary case and secondary case is called serial interval. Simple. The onset of primary case to the onset of secondary case, the gap is called serial interval. Now you see here, the start of infectiousness of the primary case to the start of infectiousness of the secondary case, this is my generation time. Now you can correlate everything. What is latent period? Entry of organism till the point where you start becoming infectious. You are infectious. You're not having sign and symptom, but you are infectious. Then you are moving forward. Now you are exhibiting sign and symptom. Incubation period, you have developed a primary case, you have a symptom now. You are infectious also. During this infectious period, you have spread the infection to other person, the secondary case. The secondary case will also follow the latent period, incubation period, and then the secondary case will develop. So gap between primary case and secondary case, serial interval. And the important thing is the start of infectiousness of primary case to the start of infectiousness of the secondary case is generation time. Okay. Okay, let's take the 23rd question. What is the denominator in infant mortality rate? Now here only, students, before I answer this question, there are two things, rate, ratio. Please remember one thing, rate, numerator is a part of denominator. In ratio, numerator is not a part of denominator. Please remember this bottom line difference. Here what they are saying, infant mortality rate. Infant age is 0 to 1 year age. So out of total live birth, how many infants are dying? So infant mortality rate, suppose there is 5,000 live birth. 5,000 live birth, 20 infants are dying. So in 1,000 how much? Simple mathematics. 20 by 5,000 into 1,000. So 4. So 4 per 1000 live birth. This is my infant mortality rate. So what I said, numerator is a part of denominator, it is a rate. So this infant deaths are live births only, so they are part of this 5000. So infant mortality rate is expressed in 1000, so it will be 1000. Now, the current SRS, this will help you to remember the data also. SRS data, current SRS data. The crude death rate, I have already mentioned earlier, it is 6. Under 5 mortality is 32. Infant mortality rate is 20. Neonatal mortality rate is, so infant mortality is 28, neonatal mortality is 20. Early neonatal mortality is 15. Late neonatal mortality is 5. Post-neonatal is 8. Perinatal mortality is 18. Stillbirth is 3. You will say how to remember all this. Now what I'll do, just a second, go back to the slide. What I'll do, students, whenever such question, it's very easy to remember. Put here, let's take, birth. 7 days. 28 days. 1 year. 5 years. 28th week POG, period of gestation. Now, from birth till under 5, anyone dying between birth till under 5 is under 5 mortality. In India, it is 32. Means 32 kids are dying in between birth till 5 years of age per 1000 live birth. Out of this 32, 28 are dying within 1 year of age. So this is my infant mortality rate. So out of this 32, 28 are dying between 1 year of age. So how many are dying between 1 year to 5 year now? Only 4. 28, 32 minus 28 is 4. Okay. Now I also know that from birth till 1 year, which is my neonatal mortality, that is 20. So out of this 28, 20 kids are dying in between 1 month of age, which is my neonatal mortality rate. So what is my post neonatal mortality? Is 8. 28 minus 20 is 8. Okay. Now from birth till 7 days, the data says 15. So this is my early neonatal mortality rate between kids dying between birth till 7 days. So if it is 15, what between 7 to 28 days? It is 5. So what is this 5? It is late neonatal mortality rate. What is the stillbirth? Means kids dying, there is no signs of live birth. It is 3. So from 28 week of period of gestation till birth, it is 3. And so one more indicator is perinatal mortality rate, which includes stillbirth, and it also includes early neonatal mortality rate. So it is 3 plus 15, which is 18. So you can understand this is used by program people, public health expert, to understand which age group is the most important. If you ask me, out of 32, 20 people are dying in the age group of birth till 7 days. So that age group is most important. Let me be focused in that age group. So the programs are directed accordingly. 1 to 5 year, only 4 kids are dying. In 1 year, 28 kids are dying. So I'll be focused more on 1 year. Within 1 year, I'll be more focused in 1 month. Within 1 month, I'll be more focused for first 7 days, right? So this is the way to understand the concept. Okay. Number of maternal deaths per 1 lakh live birth. So is called as maternal death per 1 lakh live birth. This is females. This is kids. Numerator, denominator. Numerator is not a part of denominator. So the answer is maternal mortality ratio. It's a ratio. Numerator is not a part of denominator. Okay. Now here only, it is very important to remember the current MMR of India. Maternal mortality ratio, and I have given you a trend from 2014-16 where it was 130 maternal deaths per 1 lakh live birth. It has come down in India is to 97 per 1 lakh live birth. It has reached to the target set by India National Health Policy 2017, where it said that reduced to 100, less than 100, and it has reached to less than 100. Now, Sustainable Development Goal says that by 2030, can you reduce maternal mortality ratio to less than 70 per 1 lakh live birth? So we are 97 here. We have 10 years odd. So we need to 10-year odd means why I say because the data corresponds to 1820. We are in 2024, but the latest data is of 1820. Subsequently, we'll get this. So we have the data. We have the period of 10 years, and probably then we will see whether we reach this SDG goal set for MMR or not, right? Okay. Now, let's take the 25th question. On occasion of International Millet Years 2023, you are preparing a report to present to the Government of India, showing comparison of nutritive values of various millet in percentage. Okay, so I have to show my data in percentage. So whenever you are showing data in percentage, students always use pie chart because this helps you to demerge. Suppose if I have drawn this, so this is my 60%, by default this becomes 40%, right? So pie chart is the best way of demonstrating data when it is in percentage. Okay, the best way to plot trends in the incidence of diarrhea disease in given area, right? For example, January, February, March, April, May, June, I am trying to show the incidence of diarrhea. So 2 cases, 4 cases, 3 cases, 5 cases, 8 cases, 9 cases. So the best way of showing the incidence of disease, diarrheal disease, we have to plot it, so it becomes line graph, right? Now, let's take the next one. We are preparing a report to present to Government of India about number of students with malnutrition in your state in different age group. So you have a class interval 0 to 5, 5 to 10, 10 to 50, and you want to show the data, number of students with malnutrition, so quantitative data, class interval. The best way of showing is histogram. So please show with histogram. Okay, so histogram, the best thing to remember is it is a graphical representation of quantitative data which is in continuous form. So x-axis here you can see the MCHC value, and y-axis has got number of women. So we can show these bars, histograms, and if we connect the midpoints, if you connect the midpoints here and you connect this, so you get the next one which is called frequency polygon. So midpoints of class interval in the histogram, and this is the line chart which we have already shown. It helps you to show the trends of an event over a period of time. When you are trying to represent cumulative frequency diagram, so this will definitely go above, which is also called an ogive curve. So cumulative frequency distribution curve, the best way is showing is the ogive curve. And then you're also showing a correlation, correlation between two variables, height and weight. So when you are showing a correlation, the scattered diagram or dotted diagrams are used, and it's very important to understand this correlation. So when you have a correlation, for example, one value is increasing, other value is also increasing, it is linearly moving, so it is perfectly positive correlation. Rise in one variable give rise to another variable. When you are rise in one variable gives to decrease in other variable, proportionately rise in variable leads to fall in other variable, it is perfectly negative correlation. So it is -1. So it ranges between -1 to +1. There can be moderate positive correlation. It cannot be proportionate, but it is moving towards positive. It can be moderate negative also. It is not proportionately negative, but negative. There can be no correlation also. And then can be false correlation also. Spurious correlation also. Okay. Okay. Let's move to the 28th question. The urban area of Delhi has 4,000 people with different religions. Okay. So I have a 4,000 population with different religions, heterogeneous population. research is being done to study the dietary habit of the population. Okay, I have to do a research on this population, dietary habit of the population. What technique should I apply? Which sampling technique should I apply? So when a population is heterogeneous, the best way of doing is, can we do stratification? I'll show you with the example. So let's do stratified random sampling. Just make heterogeneous population into homogeneous population, and then you try to do random sampling in that. Okay. The next one, in a WHO recommended expanded program on immunization cluster sampling, so WHO 30 cluster technique, which is EPI cluster sampling, is done, which age group they select? Please remember, when we are doing EPI cluster sampling for WHO uses, the age group they use is 12 to 23 months. And there is a reason behind this. Why? Because we want to assess full immunization. Full immunization is from birth till 1 year. 1 year birth, all the vaccines which is scheduled is taken by the child or not. So for assessing this action, you need to select the child from 12 months to 23 months. So you pick randomly, for example, 15-month-old child, and you ask the mother of the child that, did your child receive all the vaccines between birth till 1 year? If the child has received all the vaccine, it is fully immunized. If the child has not received all the vaccine, it is partially immunized. So the age group which we select is 12 to 23 months in the WHO EPI cluster sampling. And full immunization concept is, you select the child, 12 months to 23-month-old child, to assess whether the child has been vaccinated, all the vaccines till 1 year has been given or not. You cannot select any child of 8 months or 9 months, because it has to cover till 1 year. Let the work to be done, then only you are going to assess. The work has not been done, how will you assess that? Okay. The next one, in a study, first schools are sampled, then sections are sampled, and finally students are sampled. This type of sampling is known as, so you are doing in stages, first schools, then sections, then finally student. So my answer goes multi-stage sampling. Okay. Best sampling method, snowball sampling, simple random, systematic, convenience. So my answer here is systematic random sampling. Convenience sampling is not important. It's a biased sampling based on your convenience you're doing. Systematic random sampling, you're doing randomization, random sampling also, along with you're following a pattern. And snowball sampling is just that I have selected you, you are selecting your known ones, he is selecting, so gradually the ball is becoming bigger and bigger, so that is called snowball sampling. I'll explain all this with photographs that will help you. So you see this, so these are the population. In simple random sampling, there is every possibility, everyone has got equal chance. He can be also selected, he can be also selected, anyone can be selected. So randomly I picked this, randomly he got selected, randomly he got selected, randomly he got selected. So it's not my fault I selected blue ones more, or the yellow ones, or the other color one less. It's a simple random lottery method, I have selected that. Systematic random sampling, what I have to understand, you have to follow a system. Let me give you an example. Suppose there are 1,000 population, right? I need to select 20 people from this randomly. So I can, if I'm doing simple random, I'll select 20 people, anyone. That will be simple random sampling. But I want to follow a pattern. I don't want to be, selecting all the people from the first half or the second half. So I want to follow a pattern. So what I do, the best way is, let me divide this 1000 by 20. So which comes 50, right? So after every 50th, I'll take a person. So I can cover the entire population. So for example, if I include, 49th is my, based on simple random sampling, what I did, the first one happens to be 49. 49th I have picked. The second one has to be 49 plus 50, which is 99. Then again 50 I am going to add. then it will be 149. So what are you are doing? You are trying to follow a pattern. 50 is which you got here, you are trying to give every 50th unit you are selecting it. The first one was simple randomly, 49 you selected. Somebody will select 40. If somebody select 40, the second one will be 90. Next one will be 130, 140, no, 140. For 190, like this it will move. So if I show in the picture, so in this picture you see, every third child has to be selected. So this one got selected, this one got selected, this one got selected, and this one got selected. So you are doing random sampling, but in a systematic pattern. Okay, what is stratified random sampling? Before not going into this, let's see this picture. So you have a box where you have a square, you have triangle, you have circle. So can I say this is heterogeneous? What the question which was given to you, Delhi one. Now heterogeneous population, what I do, I am dividing this into strata, different strata. I'm trying to convert this basically into homogeneous population. Now I have all the triangles here in one box, I have all the circle in one box, I have all the square in one box. So heterogeneous population converted into homogeneous population. And from each homogeneous population, I have taken samples, simple randomly sampling. So it is stratified random sampling. So what have you done? You have only converted heterogeneous population into homogeneous population, and you have selected randomly from all the homogeneous population. So this is stratified random sampling. There is cluster sampling, stratified cluster sampling. So let's try to understand this. The first, you can see you have red color people, you have green color people, you have blue color people. So what I did, first I converted this population into, I did stratified sampling. I put all the red people in one strata, the green one in other strata, strata 2, and the blue one in strata 3rd. You can see here strata 3rd, strata 1, strata 2. So stratification done. No, strata 1, strata 2. Within that strata, I'm trying to create a cluster. So cluster 1, cluster 6, cluster 2, cluster 7, cluster 3, cluster 5, cluster 6. So this is a classic example of stratified cluster sampling. 30 cluster technique sampling is used by WHO method, which I showed, where what they do, they divide the villages into 30 clusters, and from each cluster they take 7 kids, and that makes into 210 kids, and based on this they evaluate full immunization. Okay. Multi-stage random sampling, I'll just show you here. First you identify, select district, then you select blocks, then you select PHC, then you select sub-centers, then you're trying. So you're doing in phases, right? This is multi-stage sampling. Then you have snowball sampling. Snowball sampling, as I'll give you the example. This gentleman hired these 2, this person hired these 3, this lady hired these 3, and gradually we are increasing. The ball is growing bigger and bigger. So this is snowball sampling. Okay. Okay. Let's move to the next question. Deviation of a value from a mean in terms of standard deviation. So a value is deviated from a mean and you're expressing that in terms of standard deviation. That is called relative deviate. It's not mean, it's not range, it's not standard deviation. So you're trying to see the deviation of a value from mean and you're expressing that in terms of standard deviation. That is relative deviate. I know. Let me give you a simple example to make you understand. So what the question says, deviation of the individual value from the mean, so value minus mean, and you are expressing in terms of standard deviation. Simple, keep it simple. So you're trying to, express the, deviation of a value from the mean, and you're expressing that in terms of standard deviation. Let's take an example. So data is normally distributed. What I have done, I have taken height of adult males. The heights are normally distributed. The mean of the different males are mean is 70 inches, and standard deviation I have calculated 3 inches. Okay, 70 inch is mean and standard deviation is 3 inch. I want to see the relative deviate or Z score for the individual value 65, individual value 70 and 75 also, let's take 75 also, in terms of standard deviation. So Z score, what it said, value minus mean in terms of standard deviation. So let's take first value 65. So 65 is the individual value. I want to calculate the Z score. So 65 minus 70 is my mean and divided by 3, which is standard deviation. So I get 1.67. So this is my Z score. Now what this 1.67 says? 65 inches is approximate. The person who is 65 inches, the individual value, is 1.67 standard deviation below the mean, because it is in minus. Let's take for our individual value where the height is 70 inches. So 70 minus 70, it becomes 0. Here the 70 inches is exactly at the mean. Mean is 70, your Z value is also 70. If I take an example of 75 inches, individual value, if I calculate that divided by here, so it is 1.67. So the individual value 75 inches is 1.67 standard deviation above the mean. So 65 was 1.67 below the mean, 75 is 1.67 above the mean. So this is the way we interpreted Z score or relative deviate. Now let's take the next question. In a set of given values 5, 10, 10, these values are given. Second 15 value was written as 45. Okay. Correct about central tendency parameter. The question says, okay, 5, 10, 10, 15, 15, 20. Second value 15, this one was written as 45 by mistake. So there are two things. First is 5, 10, 10, 15, 15, 20, 25. If we add this 20, 25, 40, 55, 75, 100. So 100 by how many numbers are there? 1, 2, 3, 4, 5, 6, 7. Okay. So 100 by 7 is my mean. And how many modes? So there are 2 repetition here, 2 repetition. So it is bimodal. 10 and 15 are repeated. So this is bimodal. Now, if you remove 115 from here, so it becomes 85. You remove 115 and you add 45. So it becomes 130 by 7. So 5, 10, 10, 15, 45, 20 and 25. So the mean also changes and mode also. Mode is only 10 now. So when the value was incorrect, the mean and mode both has changed. So the answer will be change in mean and mode both. Let me give you the correct data was 100. So mean was 14.29. Mode was 10 and 15. When that 15 was replaced by 45, the incorrect one, so when that becomes 130 by 7, so 18.27, the mean changed. Mode also changed. From bimodal it became unimodal, only 10 appears twice. So when the data was incorrect, mean and mode both changed. Okay. Now, the important one. In a normal curve, normal distribution curve, which we see always, we keep on studying, like this, 1 standard deviation, 2 standard deviation, 3 standard deviation, we keep on studying. The question they're asking is, what is the percentage of distribution that falls within 1 standard deviation? Please be mindful, mean plus minus, I am repeating, 1 standard deviation. You can also write this as, please also make habit of writing 1 standard deviation and mean minus 1 standard deviation. These two are clubbed and written in this way. So both is included here. So this includes 68% of the area. Mean plus minus 2 standard deviation, 95% of the area. Mean plus minus 3 standard deviation, 99% of the area. So here 1 standard deviation they are asking. So the answer is 68%. Okay. Now, the tricky one. how much population falls between median and median plus one standard deviation in normal distribution. Normally when students see the question, okay, median, mean, median, mode, normal distribution curve, mean, median, mode coincide. So median and median plus one standard deviation, normally our instinct says to answer 0.68. But can I read the question once again? If I read the question once again, it says, how much population falls between median and median plus? They are telling you median and median plus one standard deviation. The question did not say to consider median minus one standard deviation. So the answer 68 includes this to both, which is wrong. They are asking you this only. So the answer here is tricky, 0.34. Many students got it wrong, 0.68. No, it is median plus. It did not say median plus minus. Okay, half of that. Okay, let me take the other question, then I'll go with the graph. Now, suppose there is question given, mean is 230, standard deviation is 10. Then what is the confidence limit, upper limit and lower limit, when 95% is the value given? So we have just discussed mean plus minus, I am emphasizing on this, one standard deviation is 68%. We will not take this. Mean plus minus two standard deviation, which is 95%, we will take this. So mean is 230 plus 2 into standard deviation is 10. This will give me upper limit. 230 minus 2 into 10, this will give me lower limit. So it is 250 here and it's 210 here. So my answer is A. So the range is, the limit, lower limit is 210, the upper limit is 250. Okay. Now, in a group of 100 children with mean hemoglobin 10.5, okay. So 10.5 is the mean hemoglobin with standard deviation, okay, 0.5 gram. Which statement is correct? Okay, 68% means plus minus 1 SD. So 10.5 plus 1 into 0.5, which is 11, and 10.5 minus 1 into 0.5, which is 10. So 68% A is correct. 95% just you have to do 2 here. So it is 9.5, 11.5. This is also correct. Okay. So, okay. So 11 and 10. 11 and 10. Sorry, this is 11 and 10. This is, in this range, there will be 68%. Right? 11 and 10 will 68%. Based on this option, this is correct. This is also correct. Let me understand the C. So when 68% is correct in between this, what happens to the remaining 32%? In total 100%, 68% is, in between 11 to 10. So what about 32%? 32% can be below 10, can be above 11. So obviously half of that will be below 10. So 16% of 32, is 50% will below 10 and 16% will be below 11. So C is also correct, students. So all of the above is correct in this question. This C understanding is very important. How did we get to this 16? 68% is in between 11 to 10. So remaining that 32% will be either below 10 or above 11. So 16% below 10, 60% above 11, since the data is normally distributed. Okay. Now let's take the 38th question. If the systolic blood pressure in a population has a mean of 130, median 140, the distribution is said to be symmetrical? No. Positively skewed? No. Negatively skewed? Yes. The data is negatively skewed. So how do we understand positive skewed, negative skewed? It always creates confusion in the students. Let me make it explain you in a simple term. It's very easy. Let me take three values, 49, 50 and 51. So data is normally distributed, it is in sequence, so mean, median, mode will be normal. In this data, what you do, you add a outlier, something which is not normal here. The next normal thing, if I ask you what would be 52 normal, or I have to take on the lower limit, it will be 48. This is normal, 48, 49, 50, 51, 52. If I tell you to take 60, or at the second example, take 40. So this is extreme on the positive side, on the plus side, and this is this is extreme on the negative side. Now when you add this 40 here, suppose you take this 40, 49, 50 and 51. So what this negative outlier is doing is dragging the mean. So when these three numbers were there, mean was 50. The moment I took the fourth number, which is extreme in the negative side, lower end side, which is 40, the mean became 47.5. Median, which is not affected much, so it is 49.5. So just because of this negative outlier, or the lower extreme outlier on the lower end side, it has dragged the mean on the lower end side. This is negative skewed. The second example, take 60 in this, 49, 50, 51, 60. Now this 60 is a positive outlier. It will drag the mean on the higher end side. The mean will be now 52.5 and the median will be 50.5. Median hardly gets affected. So this is positive skewed. So in simple term, so when data is normally distributed, if you have another data which is outlier, extreme number on the upper end side, it will create positive skewness. If you have a outlier, extreme number on the lower end side, it will be a negative outlier and it will create a negative skewness. Go back to the question. Mean is 130, median is 140. Some negative outlier is dragging the mean on the lower end side, so answer is 130. Okay, now the next one. In an epidemiological study, null hypothesis came out to be true. Okay, you did a study, so null hypothesis is true. It's true. The null hypothesis came out to be true and you accepted it. You accepted. It was true, you accepted. But when we checked with the gold standard reality, the null hypothesis was false. So student, when null hypothesis is false, what you should do? What you should do? You should reject it. But what you did, you accepted it. You are making null hypothesis true. So you are making an error. So that error is called type 2 error. That is type 2 error. Okay. Let's take one more example. Type 1 sampling error is classified as alpha error. I'll not go here much. I'll explain this. Now try to take this. A randomized trial comparing efficacy of two treatment regimens showed that difference is statistically significant. When you compare two regimens, the difference, the p-value came to be less than 0.001, highly significant. But when we checked with the gold standard, in reality, the two drugs do not differ. The two drugs do not differ, they are same. There is no significant difference. But your study is proving that no, the drugs which are using has got a difference. The one is better than the other one. But in reality, it is not. So in reality, null hypothesis is true. But your study, you are rejecting this and you are saying no, that you are accepting alternate hypothesis. Let me put in this way. You student, you are making an error. So that is called type 1 error. Okay. Now try to understand hypothesis and null hypothesis alternate. It's very easy. Hypothesis, you make an assumption. It can be true, it cannot be true. Null hypothesis says that there is no significant difference. There is no relationship. There is no association. Alternate hypothesis means yes, there is a significant difference. There is an association. So there is some significant difference. This is the difference. Now 2 by 2 table I'll show you and try to understand. Yeah, let me wait. Yes. So null hypothesis is true. Null hypothesis is false. Now these are our response. I have rejected null hypothesis. I have failed to reject null hypothesis. You don't have to do anything. Don't go into type 1 error, type 2 error, false positive, false negative, what. Just put what is in the column and what is in the row. So column says in this box for this cell, null hypothesis true. Null hypothesis true. So what should be our response? I should accept. I should accept. What I have done in this box, I have rejected. Null hypothesis is true based on this. You have rejected based on this. So this is not same. You have done an error. That is false positive also, and it is called type 1 error. There is no significant difference. Deliberately you are proving that there is a difference. So that is type 1 error, false positive. It can be also correlated as false positive. Now let's take in this any box you can take. Let's take this box. Null hypothesis is false. What I'll do before jumping on to the conclusion, I'll put null hypothesis false. Reality says null hypothesis is false. Null hypothesis is false, and what have you done? You have rejected. Very good. Null hypothesis was false. Your study has rejected. Correct outcome, true positive. This is called power of the study. The power of the study had that the null hypothesis was false and it had the capacity to reject it. Good, very good. Now take this one box. Null hypothesis again. Null hypothesis true. And column says, and the row says, fail to reject. Fail to reject. You are not rejecting it. Very good. Null hypothesis true. Why should reject? Accept it. Correct outcome. True negative. Null hypothesis is false. I'll write here. Null hypothesis false. And you fail to reject. You are not rejecting it. So you are making an error, type 2 error, which is beta. And this is called false negative. This is my alpha, type 1 error. This is my power of the study. This is the simple understanding of null hypothesis, alternate hypothesis. Now, again, removing true positive, false positive from that, simple terms, null hypothesis, students, is true. What should be your answer? You should accept it. You should not reject it. Very good, no error. But null hypothesis was true and you have rejected it. You are making an error, alpha, type 1 error. Null hypothesis false. You have rejected it. Very good. This is power of the study. Rejected. Very good. Null hypothesis was false. You should have rejected it, but you are not rejecting it. Type 2 error. This is beta. So student, can I say here power is equal to 1 minus beta? You can increase power of the study by decreasing beta, by increasing sample size. Right? So this is the null hypothesis and alternate hypothesis concept. Okay. Now I'll not go into the same thing. I'll just give you one example. Type 1 error, alpha. What is the meaning? Meaning is null hypothesis is true. It should have been accepted, but the study rejected it. So you are making an error. So it is type 1 error. It is also called false positive error. It is denoted by alpha. Now take an example. The investigation concludes that the patient has disease. The investigation is saying, oh, you are suffering from this disease. But in reality, the patient is not having any disease. So you are wrong. So this is an example of type 1 error. The study reports that the drug is useful for a particular disease, but in reality it is not. It's like type 1 error. Study shows that the medical treatment is the cure for the disease, but in reality it is not. Type 1 error, alpha. Okay. Similarly, I'll give you example of type 2 error. The study fails to find an effect. which in reality exists. There is a relationship, there is an effect, but the study is not able to find it. So you are making an error, beta. The study reports that drug is not useful for a particular disease, but in reality it is useful, beta. The investigation declared that the person has a disease free, but in reality the person is suffering from disease, error, beta, type 2 error. Okay. Okay, I'll not go into this now. As I said, power of the study, null hypothesis false, and your study is rejecting it. Very good. So this is just because of the power of the test. So power of the test can be increased by decreasing beta, increasing sample size. Increase the sample, your power will increase. Okay. Now, a study was done, the next question was done to assess the vaccination percentage. So vaccination was done and it was given in percentage in young children. 100 children, each were selected from 5 different districts. Which of the following statistical test can be done? Compare the data set. Obviously, it will be chi-square test because the values are given in percentage. It is a qualitative data, so you can use chi-square test. Now, please remember, when you are comparing, qualitative variables, you are squaring chi-square test, which is a non-parametric test. When you are comparing two independent groups, if it is quantitative data, you are doing t-test, and you are doing for similarly, if you are doing a non-parametric test, you can do Wilcoxon rank sum test. If you are comparing paired observation, you can use paired t-test, and for non-parametric, you can use Wilcoxon rank sign test. If you are more than 2 groups, in parametric you are using ANOVA, in non-parametric you are using Kruskal-Wallis test, and if you are trying to assess the relationship between 2 variables, if it is a parametric quantitative data, you are using Pearson correlation. If it is a non-parametric data, non-qualitative data, you are using a Spearman rank correlation. This is the slide which you have to, table which you need to remember. Okay, let's take the 43rd question. A diagnostic test for a disease has a sensitivity of 0.90. The question has given sensitivity 90%. 0.90 means 90%. Specificity 90%. Question is already given. The single test is applied to each subject in the population in which the disease population is 10%. So, okay. So prevalence is disease population is 10%. What is the probability that a person positive to this test has the disease? Now the question is asking you to calculate positive predictive value. When such question comes, why I have taken this? Because it will help you to understand sensitivity, specificity, positive predictive value, negative predictive value, all. Now try to understand, and it is very easy to understand. 10% is the disease population. If my total population is 100, let's assume 100 as a total population. So 10% is diseased. Means out of this 100, 10 people are diseased. Then students 90 are not diseased. Simple. Now let's make 2 by 2 table. Disease, not disease. This can be calculated without pen and paper also, no need to worry, but I'm trying to just show you. So this is my positive, this is my negative, and this is my total one. How many diseased? 10. How many not diseased? 90. Total is 100. Sensitivity value is 90%. Now please, I'll speak 2-3 lines. What is sensitivity? Ability of the screening test to correctly identify true positive out of those who are suffering from disease. So how many people are suffering from disease? 10. What is the percentage given? 90%. So 90% of 10 is 9. So 9 will be my true positive. What is this 9? It is disease and the test is also saying positive. Again, I'll repeat. What is sensitivity? Ability of the screening test to correctly identify true positive out of total diseased. So 90% sensitivity is already given. So my true positive here becomes 9. So when my true positive becomes 9 here, 10 is the total disease, this will be 1. 10 minus 9, 1. So this is my true positive. So this becomes my false negative. Okay. Now, what the next part of the question is specificity 90%. What is specificity? Ability of the screening test to correctly identify true negative out of total not disease, which is 90 here. So 90% of 90 is 981. So 81 are those people who are not disease and they are diagnosed negative by the screening test. So this is 81. So the moment this is my true negative. So what is this 9 here? 90 minus 81, 9. This is my false positive. Now add this becomes 18, this becomes 82. So this is my 2 by 2 table created. Now what the question is asking, probability that a person positive to this test has the disease. The total positives were 18. Out of this, 9 were true positives. So what is positive predictive value? 9 by 18. And when you take percentage, it becomes 50%. So the answer is 50. So how do you explain positive predictive value? Capacity of the screening test to diagnose true positive out of total positive. Total positive was 18. Out of that, true positive was 9. So it is 9 by 18, 15% positive predictive value. What is negative predictive value here? Capacity of the screening test to correctly identify true negative out of total negative. So 81 by 82. Now if I tell you to correlate sensitivity and positive predictive value, I said sensitivity, ability of the screening test to correctly identify true positive out of total diseased. What is positive predictive value? Capacity of the screening test to correctly identify true positive out of total positive. So positive predictive value and sensitivity, the only difference is the denominator. In sensitivity, the denominator is diseased, and positive predictive value, the denominator is total positive. Similarly, what is specificity? Ability of the screening test to correctly identify true negative out of total not disease. What is negative predictive value? Ability of the screening test to correctly identify true negative out of total negative predicted. So 81 by 82. So the only difference is the denominator. Okay. Now let's take this question. Similarly, if you've understood that, it will become very easy to calculate. So there are 10,000 people. The prevalence of disease is 20%. So 20% of 10,000 students, you should know 2,000 is diseased. So my 8,000 is not diseased. This is diseased. I'm not making 2 by 2. I'm trying to calculate, make you understand. Sensitivity of the screening test is 95%. What is sensitivity? Ability of the screening test to correctly identify true positive out of total diseased. So 95% of 2000, which is 1900, is my true positive. Okay, let's put it here. Specificity is 80%. What is specificity? Ability of the screening test to correctly identify true negative out of total not disease. So 80% of 8000, which is 6400, is your true negative. I have to calculate positive predictive value. Positive predictive value means true positive by total positive. True positive I have 1900. I don't have total positive because total positive I don't have false positive now. But you have 8000 not disease, 6400 are true negative. So 8000 minus 6400, 1600 is your false positive. So 1900 divided by 1900 plus 1600, which is 1900 by 3500. So this, if you calculate students, it will be 54.3%. Now, no need to go try to understand with the options. If you calculate this, I remove this 19 by 35, it cannot be 15, it cannot be 98.3. 19 by 35 always will be more than 50. So this is also excluded. I don't need to calculate so much. So the answer is 54.3. If you go do the same exercise the same way, I can make the 2 by 2 table here also. And if I do fast, you can easily do here also. So 95%, this 1900, so this is 100, this is 6400, this is 1600, so this is 3500, and this is 6500. No, so positive predictive value is equal to 1900 by 3500. So we are getting this answer. The concept should be clear, it will be very easy to solve. Okay, let's take the 45th question. A screening test is used in same way in two similar population, but the proportion of false positive result among those who test positive in population A is lower. Proportion of false positive is lower in population A than in population B. What is the likely explanation? Why the false positive is lower in population A? Why it is more in population B? The specificity of the test is low in population A, prevalence of disease is low in population B, A. So the answer here is prevalence of the disease is higher in population A. Don't worry. Let me make you understand this. Students, please remember here, before I explain this table, positive predictive value is directly proportional to prevalence. If prevalence increases, positive predictive value will increase. Right? Now, I'll show you. Suppose I have taken one example where the disease prevalence is 1%, right? And the sensitivity is 99. There is a test, 99%, and specificity 95%. Now let's take a total population of 10,000. So 1% of 10,000 is 100. People are sick. So 9,900 are non-sick. 99% of 100, 99 is my true positive. And then 1 becomes false negative. 95% of 9900 is 9405. This is my true negative. So this is my false positive. So I have calculated positive predictive value. So 99 divided by 594. So my positive predictive value is 17%. Right? Now what you do, keep everything same, increase the prevalence from 1% to 5%. So from 1% to 5%, what has happened? Now the disease people will be 500, not disease will be 9500. So 99% of 500 is 495 now. So true positives are increasing. Then this false negative is 5. So 95% of 9500 is 9025. This is my true negative. Now this is my false positive. So when you increase the prevalence, your false positive came down from 495 to 475. So the question was saying, when the prevalence in the group A was high, that is the reason for low false positive. And you can also see this, as you increase the prevalence from 1% to 5%, your positive predictive value increased from 17% to 51%. Okay, so as you increase the prevalence, positive predictive value will be high. Okay. A pregnant woman with 2-year-old child gives a history of completing required antenatal vaccination during her previous pregnancy. Which of the following would you recommend for a current pregnancy? Now, read the question properly. So first of all, student, when you come to this question, our NIS, National Immunization Schedule, we don't give now TT. So TT option first remove. We will not take TT. We can take this, we can take this. TD is given, diphtheria and tetanus both is given. So a pregnant woman with 2-year-old child. So a pregnant woman is already having a 2-year-old child and then she has become pregnant. Gives a history of complete antenatal vaccination. So in the previous pregnancy, she was given 2 doses of TD. So what is the recommendation now for the current pregnancy? You have to give only 1 TD dose. Now what is the understanding? If it is first pregnancy, example in this case, you need to give 2 doses of TD in a gap of minimum 1 month. And if this lady again becomes pregnant within 3 years, here the question says 2 years, 3 years of first pregnancy, you have to give only 1 booster dose. So the answer is B. If the question said the pregnant woman with 4-year-old child, for example, then you had to repeat the 2 doses of TD. You have to follow this. So first pregnancy, 2 doses of TD. If the second pregnancy happens within 3 years of first pregnancy, you have to give only 1 booster dose. And if the second pregnancy happens after 3 years of first pregnancy, you need to repeat the doses. Okay. Vaccines at birth. So at birth, in our national immunization schedule, we give BCG, give OPV 0, we give hepatitis B birth dose. So the option is BCG, OPV, hepatitis B. Option is C. Okay. Below mentioned vaccines follow open vial policy. Open vial policy means once you have opened the vial, you are using it, and some part of the vaccine is left. So provided its VVM is correct, it's not expired, and you have maintained aseptic conditions, and you have maintained a proper cold chain, you can use for a period of 1 month. Right? That is open vial policy, but it is not applicable for all the policies, all the vaccines. It is applicable for hepatitis B, but not applicable for Japanese encephalitis. So this option is wrong. B, it is not applicable for BCG, it is not applicable for measles rubella. So this is also wrong. It is applicable for pentavalent liquid vaccine, IPV applicable. It is applicable for DPT, it is not applicable for rotavirus vaccine. So the answer is C. Please remember, hepatitis, all in a simple way, all liquid vaccine generally follows open vial policy. All lyophilized vaccine or vaccine in powder form, for example BCG, measles, rubella, Japanese encephalitis, they don't follow open vial policy because they have to be reconstituted with a diluent and they have to be used within 4 hours. So BCG, measles, rubella, JE and rotavirus vaccine, they don't follow open vial policy. Rest others follow open vial policy. At what age is the first dose of hepatitis B vaccine given? We all know this is given at birth. I don't want to waste time here. Now, a very tricky one. A 10-month-old unimmunized child should be given. So you are at a PHC. A 10-month child comes and he has not received any vaccine. So what all vaccine he should receive? So in immunization, students, you have to be very clear what is the ideal age of the vaccine and what is the maximum upper limit which can be given. Please remember this. Okay. Now here all the vaccines which are given. DPT is a vaccine which can be given till, I'm just quoting the upper limit, can be given till 7 years. OPV can be given till 5 years. Measles can be given till 5 years. Vitamin A can be given till 5 years. Upper limit. BCG 1 year. Pentavalent 1 year. OPV same 5 years. Measles rubella 5 years. Japanese encephalitis 15 years. Remember, vitamin A 5 years. FIPV 1 year. PCV 1 year. Rotavirus 1 year. Now let's see all this how to solve. So a 10-month-old, can we give BCG? Yes. We can give BCG. Why? Because it can be given till 1 year of age. Can we give pentavalent 1? Yes. We can give because it can be given till 1 year. OPV 5 years? Yes. Measles rubella 1 year. JE 1 year. Vitamin, it's given at 9 to 12 months, so it's already 10-month-old child. It can be given. Vitamin A can be given. FIPV can be given. PCV can be given. Rotavirus can be given. So my answer will be B. I'll see also A. DPT, when we are giving pentavalent, DPT we don't give. DPT only when we are not able to give pentavalent, and we are giving DPT as a booster dose first and second on 16 to 24 months and 5 years. Measles DPT 1, so the best option is this. This cannot be given because we are giving pentavalent. 10-month-old child. You are giving BCG, you are giving DPT. Why? You can give pentavalent. Why are you giving DPT? No. BCG, DT, there is no question of DT when we are giving pentavalent. So the answer is B. Okay, let's take this image. This is an ice-lined refrigerator. Ice-lined refrigerator. Okay, all are correct about ILR. No, the vaccines are stored in dictum. All the vaccines are stored in ILR. Deep freezers are meant for freezing ice packs. So vaccines need to be stored in ILR. Now you see the pattern of storing the vaccine. All heat sensitive vaccines are stored from the bottom, OPV, measles, BCG, and all freeze sensitive vaccines are kept above, and diluent is kept just above. So, so this is the pattern of keeping the vaccine. All are correct about ILR. Keep all vaccines, including those returned under open vial policy, in the basket supplied. So you see this blue part, students. This is the covering, and inside this there is a basket. So all the vaccines, whether used, unused one, if it follows the open vial policy, should be kept in the basket. Correct. Keep freeze sensitive vaccine at the top. Correct. Arrange vaccine as per the expiry date. Obviously, the food which is, students, we also know in our house, the thing which is going to expire early, we consume that first. The vaccine which is going to expire early, we need to consume first that. So arrange vaccine as per expiry date. Correct. Early expiry should be first out. Read the B option. Store diluent at +2 to +8 degrees Celsius at least 72 hours before use. This is wrong. Diluent cannot be stored 72 hours before use. It can be used only 24 hours before use. Diluent or not vaccine, this is only to dilute the lyophilized vaccine like BCG, OPV. Suppose today is what? 17th. I have to do a session today. So I'll store diluent in the ILR 24 hours before, means yesterday I'll put it, so that the temperature of the diluent is very much similar to the temperature of the vaccine, and there should be not any problem. There is no point of keeping the vaccine 72 hours or 5 days or 6 days before. There is no, because it is unnecessary, it will occupy your storage. So no need of storing that. The guideline says you can store diluent 24 hours before use. So the answer is B. Now you see this is typical VVM, vaccine vial monitor. So all the vaccines are equipped with this thing. You can see here, vaccine vial monitor. There are 4 pictures here. So there are 2 things. There is a circle and there is a square. Please remember, circle color never changes. You see here. Circle color is same. But you see the square color, it is white. Here also it is white, but not that good one. Here you cannot see the whiteness. Here you see darker blue. So this is stage 1. This is 2. This is 3. This is 4. Nowadays, students, we don't use this stage 1, stage 2, stage 3, stage 4. We use this 2 as usable. We use this as non-usable, right? So which of the following OP vials are usable? Only 1 and 2, this and this. You cannot use this and this, right? We say stage 1, stage 2, stage 3, stage 4, technical purpose, but when you go in the program, when our ANMs or Anganwadi or Ashas are vaccinating, they are not concerned whether it is stage 1 or stage 2. What happens if it is stage 2 also, they can vaccinate the child. So we don't confuse them that are you able to interpret it, either no, it is not in stage 1, no, it is not in stage 2. How does it matters if it is in stage 1 and stage 2? If the health worker can demarcate here, they can say no, that is stage 3, that is fine. No, you can use here also, you can use here also. So there is no point of getting into that nitty-gritty of 1 or 2. But for us, this is stage 1, this is stage 2, we can use. This is stage 3 and stage 4, we cannot use. The color of the square keeps on changing when you expose the vaccine in the when you keep the vaccine in the room temperature, the color will keep on changing. So these are usable, these are discard. Here you discard the vaccine. Now, school health services should include all the following. School health services, education of handicapped children, yes. Dental and high health checkups should be there. School health record should be there. Doctors in the premises, every day doctor, you cannot expect the doctor to be there in the